Hello everyone, this is Brenda. So Janice went over the selected models and theories that describe, explain, or predict health behaviors. Now, I will be explaining how these models are selected for educational use, and I will also be describing the roles of the health professional as an educator. Models are selected for educational use based on the following: similarities and dissimilarities, educator agreement with model conceptualizations, and functional utility. And I will explain each of these further in the next few slides. Okay, so I created this chart to hopefully provide a more clear picture of the similarities and dissimilarities of the models. As you can see, across the top we have our selected models, and down the left side we have different characteristics. So if there is an X marked in any of the boxes, that obviously means that the characteristic is true for that model. So just by glancing at this chart, you can already see what models are more similar and what models are completely different from the rest. So when you have models that share many of the same characteristics, for example, the self-efficacy theory and the theory of reasoned action, you almost don't have to choose between them. You simply incorporate both. It really wouldn't make a huge difference. Then there are models that are so different that they would be inappropriate to use for a specific educational purpose. So for example, the stages of change model is very different from all the other models, that unless the educational need is specific to that model, you wouldn't use it. So to briefly summarize this chart, on the first line going across, we see that self-efficacy theory and the theory of reasoned action are similar in that they focus on predictions and expectations of specific behaviors. And as Janice mentioned earlier, this can be beneficial in targeting outcomes of educational programs. In addition to focusing on specific behaviors, this model also focuses on intent. Another model that also focuses on intent is the stages of change model. However, the stages of change model does not take into account personal characteristics or experiences, which makes it less complex. It also differs from other theories and models in that change is time relevant, with implications for educational interventions. So we also see that the self-efficacy theory, theory of reasoned action, protection motivation theory, and the health belief model are all similar in that they all recognize internal and external factors that can modify behavior. Internal factors include the individual's experiences, perceptions, and beliefs. These four theories or models are also similar in that they recognize the multidimensional nature, complexity, and probability of health behaviors. The theory of reasoned action and the protection motivation theory share yet another similarity, in that they both believe that information is cognitively processed, followed by intent or commitment to action and the health behavior. A characteristic that is unique to the protection motivation theory is that it has a component of fear appraisal and focuses on a specific vulnerability rather than general susceptibility to illness. Also, as you can see, there is one similarity that all the theories and models share, and that is that they all acknowledge the importance of the client in decision-making with respect to health behaviors. Finally, according to the text, the most dissimilar model is the therapeutic alliance model. It focuses on the educator-learner relationship as the critical factor in building compliance. So I hope that chart was helpful. So moving on, the next factor that determines how models are selected for educational use is educator agreement with model conceptualizations. In other words, the health educator just might not agree with some of these models and therefore choose not to use them. So ultimately, the model or models that do get chosen are the ones that fit best with the educator's own beliefs. This slide shows the most dominant factor that defines each model, which would most likely be the factor that the educator will or will not agree with. So for example, the likelihood of action is best addressed by the health belief model, while attaining positive health outcomes is a focus of the protection motivation theory. Attitude and intention are best viewed through the theory of reasoned action. Belief in one's capabilities is best addressed by the self-efficacy theory. The therapeutic alliance model is best used for reduction of noncompliance through an educator-learner collaboration. Finally, the stages of change model is helpful in designing educational programs by stating the individual's readiness for change and developing strategies for interventions. So for example, you may be an occupational therapist that does not believe that your relationship with a client will motivate them to comply with the home program, but rather it's their fear of their condition worsening that will motivate them. If that is your belief, because maybe that is something you have seen over and over again in your practice, then you are more likely to choose the protection motivation theory and less likely to choose the therapeutic alliance model. Another example is that an occupational therapist does believe that the relationship with the client will motivate them to comply with the home program. And they also believe that their fear of their condition worsening will also motivate them. In this case, the occupational therapist can choose to use both models by combining the salient factors of each model. Finally, the functional utility of models is the last factor mentioned that helps determine model selection. To determine functional utility, there are 4 questions to be asked. The first question is, who is a target learner? Is it the individual, the family, or is it a group? The health belief model, self-efficacy theory, protection motivation theory, stages of change model, and the theory of reasoned action can be used for any of these target learners. That is 5 models out of the 6 we have learned about today. So given that they all can be used for any target learner, what becomes important then is for the educator to remember the probability of individual variation or individual differences. The educator also needs to consider whether or not the target learner falls into a categorical group, such as being considered high risk and or being diagnosed with an acute or chronic illness. Question 2 is, what is the focus of the learning? By focus, we are referring to the content that needs to be taught. So, for example, we may focus the learning around treatment options, adaptation techniques, or wellness promotion. So we would be thinking in terms of what model can best deliver the content that needs to be taught. The third question is, when is the optimal time for the educational experience? Optimal timing refers to the readiness of the learner. So, is the learner ready to make that change? It also refers to a mutually convenient time and the prevention of untimely delays in moving toward a desired goal. What is interesting about optimal timing is that although it is considered to be an important factor in health education, the only model that includes this factor is the stages of change model. Timing is often a neglected factor in all the other models that we discussed. Finally, the fourth question to ask to determine functional utility is, where is the process to be carried out, or what setting will the learning take place in? So the setting can be the home, the workplace, school, an institution, or a specific community location. All the models can be applied in the diverse settings. Okay, so moving on. I will now be discussing the integration of models for use in education. First, it's important to understand that theories are blueprints for intervention, and that integrating various components of health behavior models is actually beneficial in the education process. Recent literature supports model integration, and I have two examples listed here. Gebhardt and Mays advocate for a multi-theory approach to promote health behaviors and propose an integrative approach using goal theories and stages of change. Paz developed a new model by synthesizing the health belief model and the theory of reasoned action, noting that a synthesized model is appropriate for the study of persons from various cultural backgrounds. Creating new models or revising old models is necessary for the delivery of healthcare to evolve. Here, I have a list of some health-promoting factors that health educators use in a multi-theory approach to health education. So I'm just going to read them off. We have level of knowledge, attitudes, values, beliefs, and perceptions, level of anxiety, self-confidence, skills mastery, past experiences, intention, physiological capacity, sociocultural enablers, environment, educator-learner alliance, resources and reinforcements, mutual and realistic goal setting, hierarchy of needs, quality of life, and voluntary participation in learning.